Now doc, tubulointerstitial diseases, let us take up. There is an inflammation of the interstitium and there is 10 to 15% of cases tubulointerstitial diseases instead of glomerulopathies will be responsible for ARF. But so though you say Feb 1st, next November 3rd week will be the NEET exam. So housemanship may, the amount of time available for preparation will be very, very narrow. So probably once we finish the theory, I mean you read final year as such, this is the last time you are reading medicine. At least now you need to read a little more extensively gynaecology medicine and surgery. But in NEET exam they made 20 marks anatomy, 20 physiology, 20 biochemistry. So that means we need to once more start from ventral, dorsal, lateral, medial, ulnar. So there is another song that will begin. So we start a proper coaching program from the Jan 1st onwards. Every day evening 3 hours online live interactive session. Maybe what we can do is we can start with gynaecology, surgery, medicine, like that, so that you can blend both your preparation to final year. But January 1st onwards you will all be in a hemiplegic state. Nowhere you like to move, you want to, but you can sit in the home and can be able to access it online. That's another way. Okay. Now doctor, what are the causes of tubule interstitium getting damaged? Drugs are a very common cause. Penicillins, NSAIDs, diuretics, anticoagulants, phenytoin sulfonamides, they are known to damage the tubule and interstitium. Similarly, infection in the case of the children like Legionella pneumonia and Streptococcus leading to pneumonia is known to lead to tubulointerstitial damage. Sarcoidosis like collagen vascular diseases can lead to it. Now how do you diagnose? When do you suspect acute interstitial nephritis? If there is a recent infection, our patient will say, recently I started antitubercular therapy with rifampicin sir. Rifampicin is one of the implicated drugs. So any new medication, any rash, fever or any generalized body aches because any infection can lead to development of tubulointerstitial pathology along with the signs and symptoms of acute renal failure. The 3 findings which are called classical of interstitial nephritis are rash, fever and eosinophilia. They may also have pyuria, hematuria. So that is the reason doctor, any patient who has been exposed to one of the offending agents like a drug and developed rash, fever with acute renal insufficiency with eosinophilia, that is his urea creatinine have shot up along with eosinophilia, rash, fever, recently started on a drug, think of possibility of tubulointerstitial nephritis. If you do urine analysis, you find eosinophiluria. There can be microscopic hematuria and proteinuria. Now what is the other entity that you know which can lead to tubular damage? If I have a hypovolemic shock, I may have ischemic tubular necrosis. If I receive a offending drug, I may develop acute interstitial nephritis, which is damaging tubule. Is it possible to differentiate ischemic ATN from that of a drug induced cause responsible for the nephrotoxic ATN? Is there any way to differentiate? It is difficult to differentiate only on the clinical grounds. But if you take renal biopsy, whether the tubule is diffusely damaged or segmentally damaged is the differentiating factor between nephrotoxic and ischemic ATN is what you have to ultimately remember. So how do you treat? If it is infection, treat it. and remove the offending agent. Now there is one more entity which is called chronic interstitial nephritis. How to differentiate acute from chronic? Acute, as the name says, rapid deterioration, eosinophiluria is what you come across. In chronic, it is more indolent in course. For example, somebody is maniac depressive. That person is receiving lithium for a long period of time. Lithium is a drug which is known to lead to development of chronic interstitial nephritis. So how do you differentiate? If you do renal biopsy, you will find fibrosis, atrophy, which is the important feature to say it is a chronic interstitial nephritis, is what you have to ultimately remember. So there is a progressive scarring with the end stage renal disease in case of the chronic interstitial nephritis. Some people may also have papillary necrosis. There are no signs of hypersensitivity like rash, fever, etc., which is seen in acute interstitial nephritis. And which subset of people can go into chronic interstitial nephritis? Those who have prolonged UTI, reflux nephropathy, heavy use of analgesics. We all say, no, grandma, don't take those painkillers, your kidney will be damaged. Next time your grandma will say, glomerulus will be damaged or tubule will be damaged. What is your answer? Generally it is the tubular damage, which is very common. Lead, cadmium, like heavy metal exposures, and arterial nephrosclerosis, any of them can be responsible. Now doctor, you know what is meant by pelvic calyceal system in the kidney. So you have an idea what is meant by renal papillae. This papillae can undergo necrosis in certain pathologies. Which entities lead to development of renal papillary necrosis? It's an entity where papillae typically get necrosed. Analgesic nephropathy, diabetic nephropathy, sickle cell disease, UTI, and urinary tract obstruction, chronic alcoholics and renal transplant recipients. None of them have relation with anyone. Of course, these two guys have a relation. Diabetic nephropathy can land you in the renal transplant, and but these all entities are known causes of renal papillary necrosis. One of the favorite questions, short answer question in the exam, causes of renal papillary necrosis. You must be 100% sure to whistle out like a parrot. Analgesic nephropathy, diabetic nephropathy, sickle cell disease, UTI, urinary tract obstruction, chronic alcoholism, and renal transplant recipients. How do you make out the diagnosis of renal papillary necrosis? You need to do an excretory urogram. You need to pass the contrast and take a urogram, and you need to look for the changes in the papillae and medulla, and that makes you to identify the papillae got necrosed. I will show you some typical urograms in case of renal papillary necrosis. Generally there will be a rapid progression, generally there will be indolent progression, sometimes it can be rapid. Now this is a coronal CT. In the pelvic calyceal system, the papillae are only broken down into streaks of densities along with the distortion of the medullary calyceal anatomy. So this kind of papillary necrosis is characteristic of diabetic nephropathy, analgesic nephropathy, sickle cell nephropathy, and chronic UTI is what you are going to tell. Another 51-year-old man, typically excretory phase of the CT scan, you passed a contrast and you took some time for the contrast to appear into kidney, and then took another film. Excretory phase CT scan had shown small collections of the contrast getting insipiciated into the papillae due to the papillary necrosis is what need to be remembered. Once papillae necrose, where will they drop into? They typically drop into ureter, and constant dropping of this necrotic material will lead to obstruction. So there will be ureteral obstruction, which will be the ultimate consequence, is what need to be basically remembered. Then the next important entity is analgesic nephropathy. NSAIDs, aspirin, acetaminophen, simple paracetamol, acetaminophen. Any of them can lead to analgesic nephropathy. It can lead to interstitial nephritis, papillary necrosis, any of them, and can sometimes lead to acute or even chronic renal failure, is what you have to understand. So that is all the story of the renal papillary necrosis which we have discussed. We will take a 5-minute break to continue with RTA, 2-minute break, so that renal tubular acidosis is something that you need to breathe in the concepts. So be prepared. Probably if you read and come, then we can breathe it easily into you. But I hope to read and come is a long forgotten practice.